Okay.
The broadcast is now starting. All attendees are in listen-only mode.
Okay, Dr. Myers, all yours.
Okay. Hello. Today we're going to be talking about treatment for psychogenic seizures using prolonged exposure therapy, which is also known as PE, for patients with post-traumatic stress disorder and psychogenic seizures. Post-traumatic stress, we'll refer to it as PTS or PTSD, and psychogenic seizures as PNES. This is just some information on who I am and where I can be located, including my office and my email. Sometimes there are some questions afterwards, and you can feel free to send me an email. And what are we going to be covering today? 3 things. What are psychogenic non-epileptic seizures, PNES, and their psychiatric comorbidities? 2, how are those who are dually diagnosed with PNES and post-traumatic stress different than others with PNES? And how might that affect our treatment plans? And 3, the utility of prolonged exposure therapy to treat dually diagnosed patients with certain modifications made to the treatment to adjust to the symptom of seizures that these patients will present. We're going to start with a definition of seizures, definition of epilepsy, and definition of PNES. The reason that we will talk about epilepsy is because this is the most commonly misdiagnosed, the most common misdiagnosis that is made with PNES, because they are very similar to epileptic seizures. So generally, seizures are an involuntary behavioral change with movements of body parts or alteration of consciousness, loss of certain functions, for example, of speech or vision, and they can be generalized, affecting the whole body, or partial, affecting a part of the body, etc. Epilepsy, the diagnosis is given after a person has had more than one seizure, and the seizures are unprovoked. For example, they have not been produced by drugs or alcohol, and it's associated with abnormal electrical activity in the brain. PNES, behaviorally, they resemble an epileptic seizure, and they can look very much like an epileptic seizure, but they do not demonstrate epileptiform activity during recording of brain waves using EEG. And the EEG, specifically video EEG, is the gold standard to make a diagnosis of PNES, which allows to rule out the diagnosis of epilepsy. Some facts about PNES. PNES are associated with an underlying psychological stressor or stressors, and there's often a history of psychological trauma. The history of psychological trauma is important to this particular presentation because we'll be talking about treatment for trauma. PNES is not a single entity, but rather a diagnosis given due to the seizure symptoms. So this is important to keep in mind, that there can be many other psychiatric comorbidities associated to PNES. And PNES in particular is just characterized because there are seizures that come along with the other conditions. So the seizures are conceived of as symptoms of an underlying psychological condition. And there can be many variations within the population with PNES. Seizures typically represent a form of dissociation, which means an alteration of consciousness, a splitting of the mind, disconnecting in a way to the here and now. And PNES must be treated by mental health professionals. Classification of PNES, and this is a presentation made mainly for an audience of mental health professionals. So we'll talk very quickly about this. DSM-5, PNES are classified as a conversion disorder or a functional neurological symptoms disorder, FNSD. Basically, there's an abnormal central nervous system functioning of unknown etiology. There must be one or more symptoms of altered voluntary motor or sensory functions. Clinical findings will show that symptoms are incompatible with medical or mental disorders, other medical or mental disorders. Symptom of deficit is not better explained by another medical or mental disorder. And this causes significant distress or impairment in social, occupational, or other important areas of life. And from the ICD-10 classification, this type of disorder would fall under F44.5, which is with attacks or seizures. There are a number of comorbid psychiatric conditions in PNES, and the variations that you'll see in the percentages have to do with different studies and different reported numbers, but there's a range that we're reporting from lowest to highest. So anywhere from 21% to 78% will have unipolar or bipolar depression. About 50% also carry a diagnosis of anxiety disorder. Up to 25% have made a suicide attempt. Nearly 30% of both men and women with this diagnosis have had at least one psychiatric hospitalization. These are serious facts about this disorder, underscoring the severity of the disorder. Pain syndromes can be seen in anywhere from 22 to 89%. Dissociative disorders in anywhere from 22 to 91%. Personality disorders, in particular borderline and obsessive compulsive, in anywhere from 10 to 86%. And patients with PNES also often suffer from medically unexplained symptoms. Connection between PNES and PTSD. Now we're moving into the specific focus for this presentation. There's a trauma history in anywhere from 90% to higher in PNES patients. So these patients are reported to have these histories with particularly high numbers of childhood, sexual and physical abuse as compared to control groups and the general population. Anywhere from 22 to 100% will present with PTSD features. So not only have they had a traumatic history, but they have gone on to develop symptoms that are consistent with PTSD. In 2013, we published a paper where we had looked at patients with PNES who had PTSD, those who did not have PTSD, and those who had had no trauma. What we found is that up to 73% of patients reported some form of trauma. In a more recent unpublished study, we found a slightly higher number, up to 77% report some form of trauma. In this 2013 study, 47% reported sexual abuse, 43% physical abuse, 34.4% had suffered a significant loss or death of a loved one, often including a mother or a father. 24.6% had reported psychological abuse. A single type of trauma was reported in 31.91% of the patients. Two types of trauma were reported in 31.11% of patients, and three or more types of trauma were reported in 26% of the patients we looked at. So a population that is characterized by very high rates of trauma and significant rates of multiple traumas. PNES trauma and PTSD, what we have found is that when we look at gender, women with PNES have significantly higher rates of trauma in total and much more sexual trauma compared to males with PNES. It's a much more common presentation report of the type of trauma that has been suffered. And there is also higher rates of trauma symptomatology in women, higher rates of anxious avoidance, dissociation, somatization, sexual disturbances, and trauma factor, which is from the Trauma Symptom Inventory, 2nd edition. Patients with diagnosed with PNES and PTS are different than others with PNES alone. This is something that we have been realizing over the last years, seeing that within that umbrella of PNES, there are subgroups. And one of these subgroups that can be pretty clearly identified is the subgroup of those who are dually diagnosed with PNES and post-traumatic stress. There are a number of articles and posters that we've been producing over the last few years, in which we continue to present evidence that supports this. And the more evidence that we have, the better, because it's showing us that this keeps being replicated in new studies. So we do have an article from 2013, which was the one we just went over, psychological trauma in patients with psychogenic non-epileptic seizures, and the trauma characteristics of those who developed PTSD. We also had another paper from 2014 where we examined cognitive differences between patients who have PNES and post-traumatic stress disorder and those who don't have post-traumatic stress disorder. There's also been a poster that has been submitted for presentation that looks at emotion regulation and post-traumatic stress in patients with PNES. And the unifying characteristic of all of these papers and posters is that we are continuing to see that those who are diagnosed with PNES and PTS are different on the things that we are looking at, on the variables that we're looking at. They continue to show evidence that they are a different subgroup within the PNES umbrella. So the proposal is, if there are such significant numbers of dually diagnosed patients with PTSD and PNES, and if these patients have repeatedly demonstrated differences compared to patients with PNES alone, and if these patients are more similar to those with PTSD alone, let's treat them with an empirically validated treatment for PTSD, making certain modifications depending on the particular characteristics of the patient's PNES. So what I mean by this is that there will be certain modifications that need to be made to the manualized treatment to consider the event of a seizure occurring in the office or seizures that are occurring outside of the office. The evidence for the initial evidence that we have for this type of treatment being useful for those with a dual diagnosis is in an article that we published this year with my co-authors, Ermi Vaidya-Mathur and Marcella Lankman. And we looked at prolonged exposure therapy for the treatment of patients who were diagnosed with PNES and post-traumatic stress disorder. This is published in Epilepsy and Behavior and is available for reading because it's an open access article. So the question is, why prolonged exposure? Well, P has the largest number of studies spanning decades supporting its efficacy and effectiveness. So it's really a treatment that has been around for decades and has repeatedly shown that it can be used to treat PTS in a effective manner. P has been shown to be effective with the widest range of trauma populations, and it's been shown to be effective in many comorbid populations, including substance use disorders, borderline personality disorder, psychosis. And at this point, it's showing some good signs that it might also be effective with the comorbid PNES population. The rationale for P is that there are three main factors that are maintaining and prolonging post-trauma symptoms: avoidance of trauma-related situations. So for example, sleeping with the light on, not going out alone, or not going to the place where the traumatic incident occurred. Avoidance of trauma-related thoughts and images. So for example, trying to forget when reminded of the trauma, trying to push down thoughts or memories. And negative cognitions that accompany the person with this type of disorder, that include things like the world is very dangerous, no one can be trusted now, I am weak. And these naturally go along and maintain many of the symptoms, not allowing the patient to expose themselves and to learn that many of the current situations are different than what the situation that they were in when the trauma occurred. So the main procedures used in PE are going to be In order to tackle the avoidance of situations, in vivo exposure is used. In order to tackle the avoidance of memories and thoughts, imaginal exposure is used. And to tackle the negative cognitions, there is considerable processing going on in the second portion of the session. And the course of P, for those with PNES, the typical course, is slightly different than what would be seen in a PE manual. Session 1 and 2 is used to go over the overall rationale for PTSD, symptomatology, and why this form of treatment is being proposed. There's a trauma interview that collects information on the trauma and the effects of the trauma. And for PNES, we include in this trauma interview an investigation of seizure semiology and ways to respond if one occurs in the office. So we're just going to ask some questions that we'll talk about right at the end of this presentation. I'm just getting a clear picture of what seizures are like, what to expect if it happens in the office. There's also an identification of an index trauma, which is the trauma that is most disturbing and has the most effect on the person. Even if there have been multiple traumas, the worst trauma, in quotations, is selected and will be focused on. And in addition, breathing retraining is also provided. Another change from the manual that you might see in PE is that the patient is also given a seizure log, which is a notebook that is used to track seizures during the course of the treatment. Typically, the patient is asked to write down when the seizure occurred, what was happening beforehand, what were they thinking or feeling, and if there was anything that might have been a trigger. This trigger could have been even hours before or days before, and the patient is gradually, by using the seizure log, identifying triggers that may have not been evident at the beginning of treatment. Session 3 will go over the common reactions to trauma. Again, more psychoeducation of the patient, rationale for in vivo exposure, and the development of an in vivo hierarchy. Session 4 will go over the rationale for imaginal exposure and imaginal processing. Sessions 5 through 11, imaginal processing continues. And session 12, final imaginal processing and final imaginal exposure, and then review of the progress and relapse prevention. So basically following the same structure. The only difference is that you're doing a bit more work at the beginning, and through the first to the 12th session, there may be seizures occurring, and then if that happens, that is introduced into the treatment and is also worked with. Processing, which you see throughout session 4 through 11 or even 12, is a very useful component in this treatment, where a lot of work is done in terms of the negative cognitions, but also in terms of a better understanding of the seizures and triggers and so forth. The main procedures used in PE, in vivo exposure: the patient is repeatedly approaching avoided situations that are objectively safe. Very important that the situations are safe, because the purpose is to learn that many things that have been cut out of one's life or have been avoided are actually not dangerous and can be reinitiated. The patient and the therapist have to develop a list of situations that the patient has been avoiding since the trauma, and then these are arranged in a hierarchy from the least to the most challenging, so from the least distressing to the most challenging or distressing. The homework assignment we'll begin by assigning exposure to situations that evoke moderate levels of anxiety. So somewhere along the lines of subjective units of distress of 50. And the patient is instructed to remain in each situation for about 30 to 45 minutes or until his or her anxiety decreases considerably. So in other words, the SUDS reach a peak and then start to drop. The main procedures used in PE, the other main procedure is imaginal exposure. And the standard instructions are to recall the memory with the eyes closed, to imagine that the trauma is happening now, to engage in the feelings that the memory elicits, to describe the trauma memory in present tense, to recount as many details as possible, including events, thoughts, and feelings, and to repeat the narrative as many times as necessary in the allotted time for imaginal exposure. So these are the standard instructions. But what will happen in a number of patients with PNES is that there may be over-engagement. Therefore, this simply means that the retelling of the memory becomes so distressing that it becomes difficult to proceed through this part of the session. So the goal of imaginal exposure is to help the patient get through some part or all of the memory. But if the distress is too high, then that may become an obstacle and in the case of PNES might lead to a seizure. So some examples of how to modify the procedures to help the patient be able to get through this, this portion of the session is to use the past tense and keep eyes open. The therapist can increase use of empathetic grounding statements. For example, you're doing a great job staying with this memory. I know that this is distressing, but you're safe in my office here in New York City. You can have the patient also use grounding tools, for example, holding a bag of ice in their hand and switching from one hand to the next, or rubbing an object that has different textures. You may nudge the memory forward by asking, and then what happened, helping the patient to move through the memory towards the end. And other possible modifications is to make it more conversational, but still having the patient go through the memory from beginning to end, or have the patient write the narrative instead of saying it. So the treatment series of patients with PNES and PTSD with PE that we did and that has been published this year, the article that I mentioned previously, included 16 adult patients. They had all been diagnosed with PNES using video EEG monitoring. PTSD had been diagnosed through neuropsychological testing, including the Trauma Symptom Inventory 2 and clinical interview. And they were enrolled in a 12 to 15-week prolonged exposure program. Post-traumatic stress and depressive symptoms were assessed on the first session and the last session, and seizure frequency was assessed in every session. And then patient follow-up was obtained on 14 patients. The issue of patient follow-up is very important because this is often lacking in studies of treatment for PNES, and it is important to know that the gains that have been achieved by the last session are actually maintained over time. So the results were that 13 of the 16 therapy completers reported no seizures by their final PE session. The other 3 reported a decline in seizure frequency, which was significant. Some of our patients were having up to 60 to 70 seizures a day. So in these cases, a decline in seizures, even if seizures have not stopped completely, is a major change for that particular person. Significant improvements were seen on scales of depression, the BDI, and post-traumatic stress disorder symptoms using the PDS. So we saw from baseline to final session significant improvements on both of those scales. And longitudinal seizure follow-up in the 14 patients that we were able to follow up revealed that the gains made on the final session were maintained at follow-up. This is a naturalistic follow-up, and patients were contacted at different time intervals. Some were followed up several years later, some a few months later. But the overall evidence was that gains made in terms of seizure occurrence had been kept. And an important thing is that 9 out of those 16 returned to productive life. It is PNES is a very disabling condition that is unfortunately also often accompanied by disability, inability to work, inability to study, and basically a loss of independence in multiple areas of life. So the fact that 9 out of the 16 were able to return either to work or to college is an important thing to keep in mind. We have here just a table with the BDI baseline, BDA final, PDS baseline, PDS final. You're just seeing that the improvements are pretty remarkable. Seizures at baseline and last session, at follow-up, and importantly, you're seeing the time interval for follow-ups. As I mentioned, they were different depending on the patient and when they were seen. And then you see the work or school status at follow-up. So we're going to talk about some recommendations for psychologists, because we did say that there are certain modifications that need to be made to the typical manualized PE treatment. And some of these we'll talk about at this point. So at the outset of the treatment, I would say in session 1, you're going to want to obtain a description of the patient's typical seizures and their frequency. So you want to know, do they have an aura? Do they have some sort of sensation before the seizure starts that might act as an alerting mechanism? How do they start typically? Is there certain body movements or change in facial expression and so forth? What are the characteristics of the seizures? Does the patient fall? Does the patient vocalize? Is there thrashing, shaking? Is there self-harming, for example, scratching or banging of the body? Does the patient walk? Are they mobile? Is there biting involved? Is hearing, speech, or writing retained during the episodes? And how long do they last? They can vary anywhere from a minute to many hours. So this is an important thing to know. And the fact about the way in which the seizure presents is also important, so that the therapist can be prepared and expect what might happen. Is there something that the patient finds helpful during the episode? Sometimes patients will say that they find it helpful if someone continues to speak to them in a calm voice, even though they cannot respond. Should the session be held sitting on the floor, for example, on a rug? Does certain furniture need to be moved in the office for these sessions? And how long until the patient recovers? You're going to want to know this last thing, because you will hope to be able to continue the session even after a seizure occurs. Other recommendations are to have an understanding with the patient that you, the therapist, may need to touch them during the episode. So come to an agreement as to what part of the body is safe to touch. Is there a particular part of the body that cannot be touched? Is it okay to squeeze the arm or the shoulder? And if the patient falls, it's important to make sure that the patient understands that the therapist may need to hold their body or head to avoid injury, or maybe place a pillow under the head. So just so that it's very clear that there may be bodily contact with the therapist. I usually recommend to teach breathing retraining exercises right at the beginning, session 1, and make sure that it's practiced and learned. This is important for seizures occurring outside of the office or in the office. I'll explain a little bit more now. I usually recommend to continue speaking to the patient during the episode, even if they're not responding. So you're grounding the patient, reminding them that they're in an office, who you are, and that they're in a therapy session, far from where that memory took place. And after a minute or two, depending on how the episode is presenting, as a therapist, you can suggest that the episode is near its end, and at this point, you ask the patient to start focusing on his or her breathing. And this is why the breathing exercise is so important to have practice and have down. Because during a seizure, that will be one of the things that you'll hopefully be using, also allowing you to gauge whether the patient is coming out of the seizure. As soon as the episode ends, I usually recommend to process what happened, to discuss exactly what was being talked about and how that seemed to trigger the seizure. It's not necessary to stop a session just because of an episode if the patient can continue. Sometimes there's a sense that session has to be ended right away because of this, but often patients will say that they can continue speaking and that they want to continue with the session. So you can assess if the patient can continue with distressing topics. So for example, can they continue with exposure, which sometimes they can, or if you should move on to a processing phase where you're talking about what happened, what triggers there were, and what their processing is to all of this that they've been through. I do always recommend that you do not leave the patient alone or allow the patient to leave an office until they are recovered. If you have an exam room, the patient can sometimes remain there resting or may remain in the waiting room. And you may ask office staff to monitor if you're with another patient. So for example, someone in the office, just to know that this person just had a seizure and to just keep an eye on them. You should make sure that you have someone who can accompany the patient home if needed. So for example, a patient may tell you that their seizures last an hour and then they are for many hours not fully recovered. Then for that particular patient, for example, you would want to have someone who would come with them to the office and who can then make sure that the person gets home safe after the session. You would also want to make sure that you have emergency contact numbers from the outset, regardless of whether the patient has told you that they have very prolonged seizures or they take a long time to return to baseline. And unless the patient has hurt her or himself during the episode, for example, fell and hit her head or some other injury, or unless the episode is very different from the typical episodes, or the patient is not responsive for a sustained amount of time, I would usually avoid calling 911. The diagnosis of PNES has been confirmed. This is what we're considering. Has been confirmed through video EEG monitoring. And if the seizures are the typical seizures and there's been no injury, then typically you would not call 911 and you would wait and assess that the patient is back to baseline. These patients are very frequently taken to emergency rooms where they are at risk of being treated for epilepsy, and they're administered certain treatments that can be dangerous to them because they don't have epilepsy. So whenever possible, this route should be avoided. So in summary, this study that I presented now provided good initial evidence that PE may be an effective treatment modality for this population. The results showed the typical improvements in PTSD and mood symptoms that PE normally shows, plus secondary outcomes in seizure reduction. It was safe, it was feasible, there were 16 patients, 0 had adverse events, but we really need randomized controlled studies to establish the efficacy compared to a waitlist group or comparison treatment. So this is really the next step that we're hoping to move towards. I'm going to give some resources since this webinar was designed for health professionals, mental health professionals, I'm providing a website, which is for the Center for the Treatment of and Study of Anxiety at the University of Pennsylvania. And at this center, that is where training and certification in prolonged exposure can be obtained by mental health professionals. There's also a certification for supervisory status. This is the center where prolonged exposure has really been studied and developed, and would be the ideal place for training if that is the goal of the therapist. In order to find a PE certified therapist, there's also a website. It's actually a tab within the Center for Treatment and Study of Anxiety. And information on PNES, definitions, resources, upcoming events, and so forth can be found on this other website of non-epileptic-seizures.com. Publications that are available on Amazon for therapists. There is a book that came out relatively recently by Kurt LaFrance and a co-author, Treating Non-Epileptic Seizures, Therapist Guide. And there is also a patient workbook associated to this therapist book. For patients and loved ones, I wrote a few years ago a book called Psychogenic Non-Epileptic Seizures, a Guide. This is basically an introduction into what PNES is, a discussion about some of the comorbidities and treatments, and some added issues about wellness and return to productive life and so forth, written in plain English, meant more for patients and for their loved ones, but which has also been read quite a bit by therapists, is what I've been told. And there are many other books on PNES, some written by persons living with PNES, others books about testimonials and so forth that can be found on non-epileptic-seizures.com. There's a particular tab that talks about information and resources. And with that, we are finished with this webinar. We've gone over what PNES is, recommendations for therapists treating patients with PNES, and what is looking very promising in terms of prolonged exposure therapy for patients newly diagnosed. So thank you very much.